Good afternoon, America. Goedemiddag, Europe, and good morning, Australia. My name is Vernon Vincent, and I am pleased to be your moderator for today's Reshape Life Sciences webinar, the Post-COVID-19 Bariatric Lap Band Practice, Expanded Patient Access, Ambulatory Surgery Centers, and Reimbursed Aftercare Programs. Once again, we are grateful for the significant interest from all over the world, and many who will be watching the video tomorrow when they wake up. Happily, many have gone back to work and they can view this event at their leisure. As always, my personal goal and that of Reshapes is to make this time worth your time. With that in mind, let's get to it. We have an expert panel, starting with Professor John Dixon from Melbourne, Australia. We are very grateful for Professor Dixon for his extensive contribution of several very high impact publications supporting the safety, effectiveness, and broad applicability of the lap band. Today, Professor Dixon will present on the many subcategories of patients who may be ideally suited for a lap band. And we're very happy to have Michael Baptista in Jacksonville, Florida, and Dr. Adam Smith in Fort Worth, Texas, both who epitomize the ideal program leaders for complete lap band programs with long-term care enthusiastically provided, with a clear goal of obtaining the best possible outcomes with an approach that centers on helping patients keep their bands whenever possible. Dr. Baptista will talk about ambulatory surgery center procedures, especially in light of how things have changed this year. And Dr. Smith will share his formula for optimizing aftercare to the benefit of his patients' outcomes and the health of his practice. Next slide, please. A few housekeeping details. All attendees are muted. We can't see you or hear you. Please send questions via the chat function. On the right of your screen is a toolbar. At the very bottom, the last option is the chat button. We will do our best to answer all questions at the end of today's webinar. Anything that doesn't get covered, I will get back to you by the end of next week. Finally, there is a post-webinar survey. Please take a few minutes to provide your feedback. Now on to our first presenter, Professor John Dixon. Good day, John. It's very nice to have you with us today.
Good morning. It's terrific to be here. And
ability. Take it away. It's all you.
Fantastic. Today I'm going to talk about the circumstances where I believe the band is really the first choice in looking after people. Next slide, Sandy. Next slide, please. Yeah, I have conflicts that were all there. Now, this is an interesting thing. It came from the IDF, and it was a mixture of surgeons. The IDF is the International Diabetes Federation, and they went through the ideal which procedure for which patient and what was excuse me, what was important. And one of their criteria was the simplicity and reversibility of a procedure. And surgeons have often questioned that, and I'll come back to that later. Next slide, please. Next slide, please. That's it. So the areas I think there's a real choice, the band is the first choice, is in the older patient, many younger patients, those planning to have a pregnancy in the future, those with serious illness, and those with high-risk surgical characteristics. Also, of course, the people with a BMI between 30 and 40. So we're going to look around the life cycle and why there are instances why the band should be first. Next slide, please. So just fill out this slide. Just again, there's a build on it. Okay, so we need to think about the risks of obesity at different age groups. And this chart from Catherine Flegel shows that when we look at a population, actually the longest life is in the overweight category, and class 1 obese isn't much greater. But when we look at people over the age of 65, the lowest mortality, might surprise you there, is in the BMI 30 to 35 category. It's in the obese category. And that's because there are characteristics in aging that make having a little bit more fat, and therefore a little bit more fat-free mass, safe. So when it comes to operating in the elderly, we don't want to compromise them whatsoever. And this is an important area to think about. what is the risk to this patient of their weight now? Next slide, please. Now, when we consider the elderly, this is another figure looking at the mortality. This is NHANES data. And if you have a look there, over the age of 70, being obese at any stage, even over a BMI of 35, isn't a risk to your life. It might be a risk to your quality of life. And you can see the way that this flattens. Those in the age group 25 to 59 have increased risk in class 1 obesity. So as we get older, our weight's allowed to get a little bigger with no increased risk to mortality. When it's extremely big, though, there's risk to functionality. Next slide, please. Now, one of the other things about people who are getting older, and I'm in this category, strangely enough, but is that we often focus in health on things that we think are important. Heart disease, cancer, and obviously stroke and so forth. If we actually ask people who are older what they're concerned about, they're concerned, and if you look at the perceptions, this is a rare study from Canada, but it shows that, you know, the health priority for osteoporosis is high. The proportion that feel they're being looked after is low. If we look at Alzheimer's, people aren't addressing Alzheimer's. If we look at hip fractures in men, people aren't addressing it, and particularly Alzheimer's in women. But when we look at functionality, older people are worried about falls, hip fractures, loss of muscle, frailty, and losing memory. If we look at their health priority with things such as diabetes, they feel that they're very well looked after, and it's not their priority. And this actually fits with the risks. So we need a different series of criteria in the elderly, and we need to provide them functionality and quality of life. And indeed, as I've already shown you, if they're obese, the risk of dying isn't all that much greater for being obese. Next slide, please. So what we find is that when our aim for all patients, but particularly for those that are older, is to age well. We need to make sure that our patients are going to age well. So we need to think about body composition, frailty, fractures, falls, mobility. We've got an opportunity with bariatric surgery to get it right. But in fact, sometimes we don't get it right. And there's one procedure you know of that actually looks after all of these things better than any other. That's the lap band. Next slide, please. So when we ask you about intentional weight loss, and we say, what are the criteria for older people? We have a big question mark. You know, there's no criteria for that. And what I'd be looking at in older people is the people we need to operate on, people over the age of 65, need to have functional problems, issues related to their quality of life. We don't operate necessarily for diabetes or heart disease or anything like that. As you've seen, the impact on their length of life isn't altered very much. So we need to think about how we're going to protect their functionality as they age. Next slide, please. So band provides the only logical choice, aged greater than 65. Weight loss is slow, it's gentle, it can be controlled, it's adjustable. It has the most favorable outcomes for body composition. And that's because it preserves that wonderful hormone ghrelin. It doesn't interfere with malabsorption of micronutrients. It's associated with the lowest nutrient concern. And our aim should be to maximize the quality of life and function, not maximize weight loss. We need to be able to change weight loss. And a practice tip, when you're putting in a band in an older patient, consider using the big one. Why? Because if they have any dysphagia or illness in the future, you may be able to just remove the fluid gently from the band as an alternative to actually having to go in and surgically remove it. So we sort of think about those other issues of aging, then we don't have to go back. Next slide, please. Let's go to a different age group. Consider young adults. Now, I can't use the word adolescents, but consider young adults and those people in the early part of life. We've got to think about the long-term problems of gastrointestinal interventions. We need to think about new therapies that are coming, the medications, devices, advances in surgery, particularly the medications. We need to think about their low compliance with nutritional supplements. We need to think about pregnancy, and a younger age is certainly an age where we have found that the younger the person, they lose more weight with lap band surgery. Next slide, please. So, and at the bottom of that slide, and you don't have to go back, was a quote from Tom Inge. When I operate on a patient who's young, I have to think about looking after this person for life. I have to think about what my surgery will do over life. Here's a figure of all of our randomized trials, and just a point there that our adolescent randomized trial had the best weight loss of all, which is consistent with what we find in real life, that younger people tend to do better. Next slide, please. So when I mentioned earlier about reversibility, I think it's the young that need the ability to reverse it. Who needs to have most of their stomach removed when they're young, with the propensity that having a partial gastrectomy has an amazing effect on nutrition, body composition, risk of bone disease, etc., over a lifetime. These people have got many years in front of them, and we have to think about that. Surgeons believe bariatric surgeon's a definitive procedure, and they don't consider reversibility. And when we met with a group of physicians, they couldn't understand that. They believe that the greatest thing about giving someone a drug, and the drug doesn't agree with them, it doesn't suit them, is to simply stop the drug. So don't forget that you have the ability with a band just to simply remove it, and basically you've solved the problem of the band. You can't do that with a sleeve gastrectomy, and it's damn hard with the Roux gastric bypass. Next slide, please. So think about that in the young. Now, so when we're looking at the future of obesity, we are going to see the increased numbers of drugs and drugs used in combination, as we do for any chronic disease. Let me assure you that's coming. There are very effective drugs in the pipeline. We have to think about that future, particularly when we're looking after people who are young, because they will be here in 10 years' time. They'll only be 10 years older. It's not a long time, and there's opportunities for different treatments. Next slide, please. So what I'd like to now talk about, this is just looking at the ability for reversibility and the issues in the young, and why I believe it's so important. Reversibility, those long-term effects on bone, the long-term effects on body composition, the frailty that you can be inflicting on someone in old age, the neutral effect on depression that we don't see with Roux gastric bypass, optimal nutritional support, and adjustability, which is a great advantage in people all the time, but particularly in pregnancy. Next slide, please. So pregnancy, we have that opportunity to do something that we can't do with other bariatric procedures. We have an ability to design, if you like, how much weight they gain during pregnancy, which is important. I've got a figure here suggesting that there's too much weight gain, there's in gestational diabetes, pregnancy-induced hypertension, macrosomia, fetal problems. If we have too little, on the other hand, we have increased risks, malnutrition, lower birth weights, and they do occur, and they are usual. Slightly lower birth weights are usual with the other procedures, and we have that programming, that fetal programming that occurs. And if you could imagine a state where the fetus is largely or partly nutritionally deficient during the pregnancy. Next slide, please. With the band, what we've been able to show is that if we see people throughout pregnancy, we can basically dial up an effective weight loss, the most recommended weight loss. And you'll see in this group of the first 100 pregnancies or so that I've looked after, how the people who came back early in the pregnancy and late in the pregnancy actually had the best outcomes as far as their weight was concerned. And this has been further enhanced by the evidence now that progesterone that goes up enormously in pregnancy can have an effect on the stomach and the stomach size and the stomach stretching, and we really don't want obstruction in any way, shape or form during pregnancy. So the ability to adjust the band, fantastic. Next slide, please. When we looked at our first 100 pregnancies, and this has been repeated by others, we have a reduced rate of gestational diabetes when compared to these women's first pregnancies. We have reduced pregnancy-induced hypertension. We have normal weight gain for the pregnancies of the mother. Normal birth weight profile. No, we don't have exaggerated big babies, small babies. Normal birth out profile and normal nutritional outcomes. In Victoria, here in Australia, we have very good birthing data, and our pregnancies after banding are identical to the excellent outcomes that we see in our state. Next slide, please. So finally, I want to address the issue of those who are high risk and chronically ill. If we have a look there, this baseline data from the early BOLD database, and we'll see that there is absolutely no doubt that the early perioperative problems associated with the band are lowest. They're the lowest of any of our procedures, and that's of any of our procedures today as well. Next slide, please. If we look at high-risk patients, and Eric Di Maria did this fairly well, and others have done it, including Dave Flum with the labs data, we know high-risk patients. We know those that have a high risk of mortality. You'll see the classification that Eric Di Maria looked at and was well validated. Of course, we don't do open surgery now, but we do laparoscopic surgery, and we look at that 90-day mortality, and we know people in those categories: male, hypertension, high risk of venous thromboembolism, etc. Very similar data from the lab study. They added obstructive sleep apnea and impaired functional status as high risk categories. Next slide, please. So when you look at the data from David Flum's study, you'll see there the incredible safety, but particularly the risks of DVT, etc. With a composite of 1 in the band, we will see that the laparoscopic gastric bypass 4.8 times. Next slide, please. So when we look at a laparoscopic procedure, the band actually has one of the lowest perioperative mortality rates of any laparoscopic procedure, and you can see some of the data from others there. So next slide, please. When it comes to looking after our patient, when it comes to these people who have high risks or people who are very sick, we can look after them gently, quietly, and we can also recognize that they don't need to lose a lot of weight quickly. If you take someone with heart failure, renal failure, or any failure, if they lose weight quickly, they'll lose muscle, they'll become weak, and it's the last thing they want. So in fact, the band is very suitable. It's not all about weight loss, it's about functionality and health and quality of life. Next slide, please. So the group I want to very briefly mention is those that are young, they don't have high risks, but we've shown in this study and others have shown that the mental health of people in their 20s has the greatest impact, and it doesn't matter what BMI you are. So when we look at it, that's the impact when obesity is changing their life. The stigma, the discrimination, the partnering up, the education, all of those things are impacted. Next slide, please. And we'll go through the next few quite quickly, just so we're not spending too much time. You'll see here, this is the classic study. There you see Vern Vincent's name on it there. the low BMI study, looking at people out to 5 years. You can see this lovely weight change, about 17% weight loss in this group of people. It's very good. Next slide, please. Beyond that, we see the major impact on quality of life. So people BMI 30 to 40 have this impact, and this is at 5 years. It improves the first year and it stays wonderful. The middle circle there is the SF36. You can see the various functions. They're the scores for patients beforehand. The yellow ones are the US average population for this age group, and the outside ones are those in this group of patients at 5 years. It's extraordinary. They're better than the average person in the community for their age and gender. Next slide, please. In addition, we see the IW qualite, which is obesity specific. Have a look at those functionalities. Look at self-esteem, look at sex life, look at work, etc. The public distress. This is an age group, these younger people, and they're not necessarily always younger people, but these younger people really have an opportunity to be looked after, and their outcomes are fantastic. And it's not just health, it's psychosocial, it's economic, etc. Next slide, please. So finally, this is just also showing that it doesn't have an effect on depression, it doesn't have an effect on binge eating. It has a positive effect on binge eating disorder, and the effects of surgery, the effect of the band on reducing appetite and improving those health conditions, they stay the same out to 5 years. Look at hunger, 7.1, 2.6, 2.6. It just drops and stays down. That's how a band works. Next slide, please. So when you're thinking about that younger person with depression, stigma, all of those issues, really and of course at BMI 30 to 35, even there's risk in this age group, really think about the band. They've got every advantage and to have it now, and I think, you know, the other surgery is just unwarranted. Next slide, please. So summing up, what I'm really emphasizing is that there are a group of people that I think are ideal for the band. The older person, the younger people, particularly those planning a pregnancy, those with serious illness, or you know, for instance, people that are preparing for a renal transplant, etc. And of course, the BMI 30 to 40. And finally, of course, such a safe procedure is ideal to be doing in the outpatient, in the ambulatory environment. Thank you.
Wonderful, John. Extremely well done, very concise with an incredible amount of information. Having published most of that yourself, it was easy to be top of mind. So we really appreciate going through that quickly. And next, we'll move on to Dr. Michael Baptista in Jacksonville, Florida. From the US perspective, from his experience, why ambulatory surgery centers, especially now in the day of COVID? Michael.
Okay, before I go on, let me go over my bariatric surgical experience, because I have a very extensive experience in different areas. So I did my general surgery in Brazil and followed by a thoracic surgery fellowship. Then I moved to the US in Minnesota. I spent 5 years in a lab. I repeated my general surgery training going to Mayo, Rush University, University of Illinois, Chicago. I did my fellowship in minimally invasive surgery in Chicago. And I've been trained to do gastric bypass, either open or laparoscopic. Now I only offer as a salvage situation. I've been trained in lab bands since 2005 and been doing bands since then. I became a proctor for realized bands when realized bands were available. And besides proctoring cases, I provide aftercare training in Jacksonville for surgeons from all over the US. I have personally placed over 2,000 bands between lab bands and realized bands. I also perform sleeve gastrectomies and a few revision surgery, and I have been using surgery center since 2007. Next slide, please. So ambulatory surgery is commonly used. The first bariatric outpatient surgery center to be recognized by the American College of Surgeons was in 2003 in Texas. Since then, it has been used extensively, and the reality, majority of the lab band patients will have their surgery as outpatient, even if performed at hospitals. Next slide, please. I'm not going to go over the data, how safe it is to do in a surgery center. If you look at the in red there are papers from 2011, 2010, 2013, 2005, 12, 07, and they go over how safe it is to do with a patient with sleep apnea. A lot of patients have orthopedic procedures at surgery centers, and amazingly, anesthesia not always look to see if a patient has sleep apnea on those patients. For me, bariatric patients are well evaluated. They are taken to the surgery center when it's safe to do there. And again, it is a safe operation performed in both hospitals and surgery centers. And there's some ideal situations where you want to take a patient to a surgery center, not so much in some other areas. For instance, BMI really high, some surgery centers BMI above 55 or BMI above 50. The surgery centers would prefer if we do it there because of the physical space and the equipment there. Some patients, high patients in weight, the table has a limit, therefore the hospital probably be a better place to go. But for majority of patients, they can actually go to a surgery center. Next slide, please. So let's talk a little bit about technique. The procedure technique has been used extensively with great results for decades. You can use the single or multi-port approach to do a gastric band, and this can be done either in the hospital or surgery center. There's no need to change how you perform a gastric band. The other bariatric surgeries, however, have required some adaptation, so they can also be performed as outpatients. I'm just going to mention one procedure, is the sleeve. People have adapted to allow patients to have the sleeve done at surgery center. They either keep the patient for most part of the morning, and then they take the patient with IV fluid, send them home, then brings the patient back next morning, and they give more IV fluids. Or they provide a nurse to sleep in a surgery center or in a hotel with a patient the first night, and therefore the patient is observed. But what I caution is the tendency to accommodate for an easy way of doing. So I do sleeves, as I mentioned, and I use the same bougie size for years. I have great success with patients, and I don't think we should change the technique. And I heard patients having now a little bigger bougie size so the patient can go home more, I could say, safe, being able to drink and not have much issues. Again, the band, you can do the same exact procedure in a hospital, and you can do it the same exact way at the surgery center. You don't have to change your technique. Next slide, please. Safety. Again, it can be performed safely in either facility. Now, with the COVID-19, surgery centers are more likely to minimize patient exposure to other sick patients. So the number one place to expose patients to risk is actually hospitals. Patients who are very sick, they tend to go to hospitals. So you tend to have more COVID-19 patients in hospitals. Surgery centers, anyone who is coughing, anyone who has a fever, anyone who has pneumonia, they are not going to go to a surgery center, period. So there's a significant screening for COVID-19, and patients, of course, with COVID-19 are not going to go to a surgery center. So patients who are going there for elective procedures, they are less likely to get contaminated by COVID-19. Next slide, please. Cost. Surgery center has always been more attractive regarding price compared to hospitals. Patients in general like to spend less money. Even insurance patients can have a significant lower cost depending on a surgery center contract with payers. And we have to remember that insurance are getting a hit also of this coronavirus. The COVID-19 has placed the entire world in economic recession, and patients and families who have less money, the insurance companies will have less money. Everybody's going to have less money. So we need more than ever to be very conscientious how we spend the money. Gastric band surgery is generally cheaper than other bariatric surgeries. Next slide, please. So what about the need for surgery? The obese population continues to increase in numbers and associated comorbidities. It's not slowing down. Several studies have included obesity as a significant predictor of bad outcomes for COVID-19. Try to breathe when you have an excess 100 pounds on you. It's not going to be that easy. You need to oxygenate most of your cells. If you have an excess of 100 pounds, your heart's going to have a hard time, your lungs are going to have a hard time. And patients more than ever are concerned about their health. The message to act on their obesity can be another leading point for bariatric surgery. Normally a patient will get diagnosed with diabetes and then they go to primary care, and the primary care again will tell them, I think you should consider something else for your weight loss. And now with COVID, putting patients at high risk if they're obese, that may be another leading point for them to come to us for help. And we need to provide that help. FDA has approved the band for BMI between 30 and 40 since 2011. And unfortunately, we don't utilize that information. It is quite safe. Patients with a BMI, what we consider lower BMI, above 35, between 30 and 35, sometimes will benefit tremendously from losing some weight. And the band, again, is approved by FDA to be used on that population. We need to enforce more of this. Some insurance have a hard time approving, but if you're a patient and you go over this peer-to-peer review with a colleague on the insurance side, most of the time you can actually have them approve that. Next slide, please. Okay, the impact on COVID-19. I'm just going to use that highlighted thing there. Due to constraints on resource and capacity. So a paper from years ago, 2010, showed that with the new technology and due to constraints on resource and capacity, we should consider taking patients to a surgery center. And the band being safe being there, we should consider doing more patients in a surgery center. Well, guess what? In Florida, I stayed 6 weeks without seeing patient in a hospital, only emergencies, and almost 2 months without operating elective surgery because due to constraint on resource and capacity. And that's not going to go away. This coronavirus is going to stay with us for the rest of the year, perhaps a few more years next year. Next slide, please. So what is the impact on COVID-19? We are facing the greatest unemployment in history. It's going to be a slow recovery from depression. It took 2 years after 2008 depression for unemployment to stop increasing. The financial barriers are likely to stay for years. The quarantine caused population to eat more often, the ones that could afford food. Gastric band is not safest, adjustable, and reversible. It is also cheaper and efficacious. Outpatient surgery center will become more attractive than ever. Next slide. Again, I encourage patients to go to surgery center if they can. Majority of patients are outpatients. I have patients have heart history, and then those patients I'll do at the hospital. I'll tell the patient most likely you're going to go home, but if you have a cardiac event, I'd rather have you at the hospital than at the surgery center. But 80–85% of patients, the lab band patients, can have their procedure safely at the surgery center. Thank you very much.
Excellent summary, Michael, very concise, to the point. Michael was concerned that the audience today knows the information he's presenting. He didn't want to be talking sideways to anybody, but I think you've done a very good job of stating the absolute facts and the safety profile. Really appreciate that. We'll come back for some questions later.
Let me just point one more thing.
Sure.
Several years ago, about 6 years ago, my sister came to me and like any other patient, asked me, Mike, what I should have? And I do lots of things. And I told Barb, if you do your share, any procedure work. If you don't do your share, no procedure work. And for me, bariatric surgery, a brand new car, and marriage have one thing in common. The first 2 years is great. So I told her, have a band. So she had a band. Currently her BMI is 22. And I did her surgery at the surgery center, and it just happened that she had probably the biggest hiatal hernia ever. I had to do a relaxing incision on the diaphragm on the right side so I could close that hiatal hernia, and got it done safely, and she's still enjoying a life of someone with a normal weight nowadays.
Well, thank you very much for sharing. That's putting your heart where your mouth is. Thank you, sir. And we'll move on now to our last presenter today, Dr. Adam Smith. Adam, good afternoon, good evening in Fort Worth. Thanks very much. Adam's going to talk about his practice and how it makes it good for the patient and good for his program. Go, sir. Michael, Adam, please turn on your microphone.
Oh, forgot that one. So started doing bands early on. Went to my first workshop in Tijuana in 2001. We got proctored on our first cases in 2002. And shortly after all of that, I found that I was operating on people that were not any heavier than I was. I had sleep apnea, I had glucose resistance, plantar fasciitis, I'd herniated a disc, had terrible GERD, and I was generally an unpleasant SOB. And my partners will attest to that. I'm not now, I'm sweetheart now. I had problems working. I was heavy. I was nearly 300 pounds. And about, a year in, or maybe less than a year in, I got a call from a patient. And nothing good calls you on Friday afternoon, as you surgeons all know. And this guy called me up. He was from East Texas. He said, "Doc, I need to tell you something." I said, "What's up? What's your problem?" And he said, "I tied my shoes for the first time in 10 years today." And I looked down at the flip flops that I wore all the time, and I felt very embarrassed. So I rolled the dice. I had my band in the end of 2002, and 18 years later, am I a perfect patient? No, I suck. I'm the worst patient on the planet, but I'm still about 70 pounds down. I got as far as 100 pounds down, but I married a Cajun who feeds me, crawfish and cream sauce all the time. So I'm a bad guy. I'm still about 25, 30 pounds overweight, but I'm healthy. I'm on no meds other than vitamins. So we were early on. He mentioned Texas. We started doing lap band ambulatory in Texas early on in the 2000s. And I've done a little over 6,000 lap bands, and I've kind of inherited the patients of some other surgeons that have now retired. And so we're following generally in the neighborhood of about 10,000 band patients between the four of us. Next slide, please. So here's some myths. And this happened early on in the bands because everyone wanted to get in the game. Here in the DFW area, lots and lots and lots of bands were placed. And a lot of the doctors that were placing bands didn't want to mess with the patient afterwards. They just put the band in and would have them a variety of different models, some of which were good and some weren't as good. There was an organization called Medical Edge that bought a bunch of primary care practices, and they decided that they would build their own surgery center, and they would hire surgeons to go place a band. And you guys, y'all just do surgery. We're the primary care guys. We're best equipped to take care of these patients long term. And so they would bring a surgeon in to do the band, and then they would be sent to their primary care doctor to do their fills or their band adjustments, and it basically sucked. They're no longer in that business, and the guys were good doctors, but when you're seeing one patient for blood pressure, one patient for their diabetes, one patient for their diabetic foot, here's a band patient, let me adjust their band, and it didn't go well, which is okay because we picked most of those people up. But the guy from that business actually stood in my office and told me I was not the best person to take care of my post-op patient. I needed to leave that to them. I showed him the door and told him not to let him hit it in the butt on the way out. So the other myth is band care is a loss leader, that it's too time consuming, and by doing a lap band, you're gonna fill your office up with all these band patients coming in for their band adjustments and stuff. You're gonna lose a bunch of money. That's not true, and I'll get to that in a little bit. The third myth is not really a myth. Of course, we're going to use an algorithm of some sorts. We had to establish a baseline of how to adjust our bands, especially in the beginning. So I'm going to say, but no two patients are the same. Every patient's sensitivity to restriction is different. Every patient's anatomy is different. Every patient's toleration of adjustment is different. So if you get dogmatic into a particular algorithm, you're going to have a problem. The fourth one is you can always tell by the patient's symptoms whether they need an adjustment up or down or none? Well, not really, because patients sometimes lack intuition. Patients are really not in tune to what's going on with their body, even though they think they are. And also, patients aren't always 100% truthful. We have this thing called the internet, and people get on the internet, and Aunt Sally has 7.5 cc's in her band, and you only have 5. Your doctor ain't doing a good job. You need 2.5 cc's out of your band, or you're not going to lose weight. I mean, I hear this kind of stuff every day, and it is so hard to explain to your patient that, listen, you're unique. You cannot compare your volume to someone else's volume because your volume is unique to you. The incremental change is what's important. How you feel is what's important. How you're performing is what's important. I don't care about your number. And they have to like force me to tell them how much is in their band because I don't want them to obsess on it. And I will if they force me to, but generally I say, you're doing good. You know, if you're losing weight and you're not gaining weight and you're getting early satiety and everything's going well, I can't improve on that. So the fourth myth is there's only one way to provide aftercare of the band patient. No, you have to customize your program for where you live, your patient demographic, your number of patients, what you're doing. You have to customize how you take care of your band patients to your practice. Next slide. Well, trying for the next slide. Okay, so how have we evolved? We did our course in Tijuana with Dr. O'Brien and Juan Antonio. It was a great time, great course, great education. And we were initially taught to do post-op swallow studies on everybody, and we did our adjustments in radiology with a tech and a fluoroscopic machine and everything. And that was good because it was a brand new thing to us. And, you know, we were just learning how to access this. And, you know, we weren't used to accessing ports and things. So then we started having these total care or aftercare courses, and we slowly transitioned to getting out of the radiology suite and doing adjustments just by palpation and by algorithm and using water. And, you know, that worked pretty well. And we had good outcomes. And we learned that, well, the early myth was that the size of the barium stream on the swallow had to look like this much. And that's bogus because the size of the barium stream going through a band has no bearing to the patient's tolerance or feeling of satiety. So you can't just guess or make everyone the same size. We've done it. We tried documenting that with barium, didn't work. We tried it with a manometric catheter, a company called Crospawn, who I don't even know if they exist anymore. They had a manometric catheter, and we would put this thing down and adjust the band in the OR to a certain pressure. And guess what? It wasn't reproducible. Some people had great restriction with that. Some people had to be deflated in the recovery room. And some people, like, you couldn't tell you'd done anything. Next slide. So fluoroscopy versus palpation, you know, Dr. Wren had a great algorithm, which is still our baseline guide. I mean, we still kind of use an adaptation of her algorithm for our initial 3 adjustments. And, you know, you can do it the way you want to. We bring people in once a month for the first 3 months, whether they need to or not. We assess them and determine, do we need to add fluid, yes or no, and if so, how much? And we generally follow that algorithm, of course, based on what kind of band they have. You know, we're not going to use the same fill volume on an old 10-centimeter band that we use on an AP standard or an AP large, so we obviously aren't stupid. We customize that based on what surgery the patient had, what band they had. You have to really hear what the patient isn't saying. How are they performing? Numbers don't lie. If they're losing weight, they're doing great. If they're not losing weight, then we got to figure out why. Is it a matter of adjustment, or is it a matter of what type of food partake they're taking, right? If they're eating chips, cookies, crackers, and sweets, it doesn't matter how tight or loose that band is, they ain't gonna lose weight. But if you really believe they're doing what they're supposed to do, that they're eating protein and complex carbohydrates, which we also sometimes call vegetables, and they're not losing weight, then you can go from there. So you're relying on your patient's honesty, and you got to get to know your patient. You got to know who's telling you the truth, who isn't telling you the truth. And that doesn't make people bad people if they don't tell you the truth. They're just ashamed or have whatever issue that they don't want to come clean with you. And you have to create an environment where the patient is comfortable being honest. That's the first step of being successful taking care of a band patient, is trust. Frequency of patient honesty, not always 100% common. Next slide. So we use the green zone chart. We have a copy of the green zone chart in every exam room in our practice. We have the green zone chart everywhere. We have the little cards that we give to the patients that have the green zone chart on it to just drill it into their minds that more isn't better. More isn't better, more isn't better, more isn't better. Just right is better. So, you know, we all know the yellow zone, that's easy. You know, if they're wide open and they can eat an enormous amount of food at a time, that they need an adjustment. They need fluid added. The green zone is the hard one, because your patient that fills out the questionnaire, and we'll show you that in a minute, that says they're doing all the right things and they're still not losing weight, do you add fluid to someone that the questionnaire looks like they're in the green zone but they're not losing weight? That's a toughie. And it's really hard to convince your patient that you believe is in the green zone that they don't need fluid, because they made an appointment, they came in, they wanted fluid added to their band, and by golly, I want fluid in my band because I don't have enough, I need more. It's like when we were little kids and we went to the doctor with a viral illness and mom and dad wants to get a penicillin shot. It's the same concept to people. They get in their mind that if they come to the office, they need something. So the hardest thing to do is to convince a patient that they are actually in the green zone. Next. So here's the green zone chart we have in every room. The hard part is the red people. Red people come in, they have these symptoms, and they still want fluid. More. Because I'm not losing weight, doctor. I know that I'm spitting up in a trash can, or I've been hospitalized for pneumonia twice, or I'm having horrific reflux, but that has nothing to do with my band. That's just my reflux. I need more fluid in my band because I'm not losing weight. Well, you're not losing weight because the only thing you can get down is lobster bisque and Oreos. So getting a patient convinced that we need to decrease that amount of volume in their band is also challenging. And here again, it revolves around trust. Next slide. So here's some myths about fluoroscopic assisted adjustments. There's a perfect size of stomal opening based on barium. Nah, doesn't mean a thing. Nobody mixes their barium the same. Some people use water soluble instead of barium. The radiologist is the natural enemy of the band patient and band surgeon. Imaging is a substitute for adequate history and physical. Inconvenient, not cost effective. All of these are not true. Next slide. So what I like about fluoroscopic guided adjustments is one stick access. I see a lot of people, thousands and thousands of bands have been done in the Metroplex. 2 guys retired, 1 guy got convicted and gave up his license. And we got all these band patients out there that need someone to take care of them. And they'll go somewhere and someone will dig around and stick them 10 times without ever hitting their port. And then they hit their tubing or whatever and they get a leak. And I'm good. And if I'm in the ER or something and someone needs a deflate or something, I do it by palpation all the time. But if I'm in the office in a controlled environment, I can do a one stick technique 99.9% of the time, no matter what the BMI is or whether the port's kind of flipping or spinning or whatever. And so the main thing is it keeps me from hitting the tubing or the side of the port, or hitting the membrane of the port at a shear angle, which then can lead to a leak and have a port replacement. Combining the band adjustment with contrast will tell us early prolapse or symmetrical dilation for the patient that sounds like they're in the yellow zone, but they're really in the red zone. So then you can show that patient the picture and say, you need fluid out of here. You need fluid out. I'm not giving you fluid. I'm taking fluid out, or you're going to end up getting your band out. So when you visually give them that picture, then they can finally start to understand, okay, I'm going to listen. I'm going to listen. It gives you feedback on your band orientation, which tells you whether you're in a world of hurt on a slip. And it also provides continuity of the band tubing. Do they have a leak? Do they have a disruption? Have they come apart at the connector? Next slide. So we started out in the radiology department of the hospital. That was terrible. It was time consuming. Scheduling was hard, inefficient, expensive for the patient, other people butting in. You never had the same tech twice. So we bought our own C-arm in the office, and patients had a terrible experience at the hospital. Hospitals are the worst place to go to. Whether you're a surgeon or a doctor, I never want to set foot in a hospital. I want to go to my surgery center. Next. So the ultrasound, we flirted with that. It was inexpensive. It kind of helped locate the port on high BMI patients, but for me, it really wasn't any better than palpation. Next. So we got rid of the radiology department, got our own C-arm. We grouped patients in groups to bring them in, and we have a separate post-adjustment waiting area for them to sit and relax and drink some fluids to make sure we haven't over-adjusted. And it's kind of like a mini support group. We keep an eye on them in there, make sure they don't start talking about crazy stuff. And so the patient not only gets their band adjusted, they get interaction with other band patients, positive feedback, encouragement, support, and it's all about support. The support group is very, very important, and that's a key part of our process. We have a support group meets every Tuesday night. They're meeting virtually right now, but they usually meet in our office with either a doctor, a nurse, or a licensed counselor in there to make sure everyone's helping each other get through this journey that they're on. But the C-arm helps us pick up early slips where we can intervene, symmetrical pouch dilations, and one stick anchor. We do not use the X-ray to tell us how to adjust a patient. We use our brain and our ears and what the patient is saying to help us adjust the patient. We use the C-arm just to make sure that everything looks okay, that we hit them with the first stick. Some of us do this supine. Some of my partners do it standing. You have to compensate if you're doing it supine. You have to realize that it may not empty as well. The only thing we're really looking for is to make sure they're not regurgitating or aspirating or that they have pathology. I picked up an epiphrenic diverticulum in the office this week. Someone that has had a band for 17 years. She's never had a problem. She hadn't had an adjustment in 2 years. She's done great, 120-pound weight loss. She says, doctor, I have the worst breath in the whole world and I'm having reflux. And we go in, we take a look, and she's got an epiphrenic diverticulum. If I send her to radiology at the hospital, I'm not going to get that information back for a couple of weeks, and then they'll probably misinterpret it because they always say the band's too tight, too loose, too high, too low, or, a wrong fee angle or whatever. So I try to keep my patients out of the hospital and especially away from the gastroenterologist and the radiologist. Next slide. So we charge about $150 for our cash patients. Of course, their first 6 months are on the house, right? Because we want our patient to get out to the best possible start they can. And we bring them in every month for the first 3 to 6 months, whether they need an adjustment or not, just to make sure they're on track, to make sure that they're learning the green zone, that they're learning where to be. And so after 6 months, we usually only see our patients annually after the first year. And we do ask them to come in every year so that we can just take a look, see how things are going, access and adjust as needed. And that costs $150. That's fairly common in the Metroplex. Next. So most commercial payers will reimburse. I usually will do 20 band adjustments in a 4-hour clinic. So about 5 patients an hour. That gives me time to assess their green zone, to talk to them, reinforce them, keep them going. So this is about it. And this got us going when times got tough, when the band tanked. Our aftercare kept our practice alive until we got volume reestablished. Next slide. Okay, this is what we use on every single patient. We like to either do it verbally or written. And y'all all have this. This is available to you. I encourage you to use this and keep going. I'll wrap it up. Okay, patient arrives. We do a history and physical, fill out the green zone sheet, and then make a decision on whether to do the fill. And here's kind of what it looks like. Next slide, please. Access the port, adjust based on symptoms, do a contrast. If we think someone has a slip or a food bezor or they're obstructed, we use water soluble. Otherwise, we use dilute barium. Next. So here's our setup. This is my nurse who volunteered. She's also a band patient. She's lost about 70 pounds. She's doing great. So we access the port, 1 stick. Next. Give her the sip of barium, look to make sure she's not regurgitating. What have we learned? Many high-profile band surgeons have retired or quit. Band patients are out there needing our help. They know that if they come to us, we're going to take care of their band. We're not going to just convert them to a sleeve or bypass. It helped us during the slow times with financial stability. And we take all comers unless we don't like them. You know, even people that we're in Texas, so we have a lot of patients that went to Mexico and had their surgery and then they're out on their own. I mean, they're just on their own, and we'll take them on unless they like, you know, I'm not going to mention any names. There's a couple guys down there that says, oh yeah, Dr. Smith and Dr. Snow are my partner. They'll take care of you from here. Oh, on the house. It's like, oh no, my precious, you're going to pay. You want me to take care of you when you didn't have surgery here. But we take them on unless they're not nice. I don't take care of people that aren't nice. You shouldn't either. You know, we're out there, but it's all about our lifestyle and their lifestyle. So if I don't like somebody, I tell them, I'm not going to take care of you. I don't like you. Next slide. I think that's it for me. We get a lot of referrals for patients who were misled or lost or just thrown out there. We get self-referrals. It has built our practice. And we believe that the band is still a very valuable asset for us. Just like John said, the lower BMI patients, childbearing age, high-risk patients, or patients that just want a band that's something customizable. You would never get the band out of me. Lord willing, I'll go to my grave with it, and not anytime soon. I appreciate the opportunity to visit with you guys today. I'm going to turn it back to Vern.
All right, thank you very much, Adam. Very personal presentation with a lot of good data and experience as well. And you're looking fine there, sir. You're looking fine. Your life with your band has been an impressive inspiration to a lot of people. I have the next slide and the whole faculty back on screen here. We do have a couple questions, and leave this ad. Go ahead and go to the last slide so people can read the last slide while we're talking about this upcoming webinar. You'll hear from us soon about Reshape Care. So just leave that there and have a look while we discuss. Michael, question for you about transfers and outpatient considerations. Do you have to have special considerations in place for if you needed to move somebody quickly and admit them somewhere? How big of an issue is that, and has it ever happened?
Yeah, if I take someone from other practice?
No, if you have somebody in your outpatient center with an urgent situation that you need to admit to a hospital.
I see. To perform surgery at the surgery center, you need to have privileges elsewhere, hospitals, so you transfer the patient. Knocking wood, I have yet to transfer a patient. I'm
Okay.
OCD, So it doesn't happen.
All right, another question for you. You mentioned that you do peer-to-peer review and get low BMI approved. We've heard really mixed stories that that's really hard, and you say it's not that hard. How do you do it? Maybe right now you just say it's successful and we really need to come back to you and capture that information, but how often, what percentage of times are you successful?
Well, a while ago it was very difficult because people say that gastric band is experimental still. And I think they are getting a little embarrassed to say that gastric band is experimental. So if you work for BMI 35, you should work for someone BMI 32 or 31. And the same criteria, having a significant disease, is valid. So when you throw on them that FDA has approved for BMI between 30 and 35, they should approve. And if you get, I'm sorry for my colleagues that are hearing me, that works in an insurance company, but if you got a moron colleague that always say no, 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 you're not going to get a yes. Doesn't matter what you say. So those are given. Don't waste your time.
Okay.
Now there are others that are more considerate, and you go over data with them, and they will approve.
Okay, I'm gonna challenge. We're gonna come back to you with our reimbursement consultants. We are going to define exactly what you do, and maybe a future webinar will be on that topic, because this is really a key area that people have given up trying to get low BMI approved. Adam, a question for you. How do people find you? You're willing to take people from St. Elsewhere, correct? How do they find you and make that happen?
Well, we have a pretty strong digital presence here. The two guys that retired sent letters to their patients when they retired and said that we were willing to take their patients on. We just digital. We're out there. Our website. We're aggressive. You know, there's 4 surgeons in our practice. 3 of the 4 surgeons in our practice are super duper band dominant. One, he's still a non-believer, and we hope to convert him someday. But so we send him all the D switches and all the stuff no one wants to do. But we're digitally. Most people find us through the internet, and we go from there.
And with Reshape Help, we're trying to educate patients that if you want to keep your band in Dallas, Fort Worth, Ultimate Bariatrics is a good place to go.
John Dixon. We do not charge a transfer fee. We just charge an initial consultation when they come in. We don't zap them, penalize them for not having surgery with us.
John, a generic global question. We have arguably, as you presented, the safest, lowest risk, most impactful procedure. And at prior courses and conferences, I've heard you say, what other single intervention can any physician or surgeon do to have so many impacts on so many diseases and conditions and issues? What is the biggest problem? I'm going to put you on the spot here. What is the one thing we should be doing to change the low volume of cases right now? What is the missing secret sauce?
Well, the greatest problem in obesity management today is a thing called weight stigma. And stigma is this, it affects patients very badly. It makes them worse. That's the blame and the shame. Unfortunately, it extends to those people who treat weight and to some of the treatments. The stigma that has been around the band is extraordinary. It's been demonized without any, I mean, it is the best quality procedure we have. We've got randomized trials, we've got mortality data, we've got everything. And surgeons elsewhere are doing a lot of procedures that don't do anything. So we've really got a credibility problem. We must stand up for our patients that they need better care, that they need options, that they need everything that works. We've got to be very clear that drugs work. We've got to be very clear that some special diets and meal replacements and very low calorie diets work, and they can all be worked together with surgery. And the lap band patient is just in the ideal position, if they've got a broad practice, to be looked after. We must get the patients to demand. We need patient support. OAC needs to be really supportive of getting all surgery done, but particularly banding again. We just got to get through this rubbish of blaming and shaming, because the band, like Coca-Cola and McDonald's, has been blamed and shamed, but they might have reasons for being blamed. The band has no reason for being blamed and shamed. And people will tell me, oh, it's the FDA are worried about it, our TGA are worried about it. They're not. They're not at all. They're not going to remove it. They know its efficacy, they know its safety, they know the outcomes. None of the other surgical procedures have been tested in such a way. None of the others are as safe. You know, the idea that any problem with the ban means take it out is just lunacy. So we've really got to be very active in defending stigma, discrimination, and blaming and shaming, because it extends to every treatment of obesity.
Thank you very much, John. Very, very eloquent. We are a bit over time. If there are other questions, we will, as I promised, get back to you later. If you're looking at our last slide here, our next upcoming webinar, date to be determined, we'll be announcing a new program, Reshape Care. At a time when you are grappling with the impact of COVID-19 on your patients and practices, you don't want to miss our upcoming webinar about Reshape Care, a virtual health coaching program. This high-touch virtual service enables you to optimize management of your new and former patients by providing a turnkey, reimbursable service proven to improve treatment and health outcomes for obesity and associated chronic disease. So stay tuned. This is pretty exciting, something very big and new for Reshape that will support our lap band patients and all patients. With that, gentlemen, thank you very much for your time to prepare, your concern and interest today, your honesty and sincerity, very palpable, very much appreciated. Excellent job, everyone. Thank you very much. There is a questionnaire, remember, as you close the webinar, if you would please complete the survey. To all a good day and good night, Europe. Cheers. Bye-bye.
Stay safe, everybody.